all right, don't worry. We'll get the jab. I'm going to put my timer on because
You're not using this.
Oh, I'm not using this. Yeah, I know.
Yeah.
This is okay. So we don't go over time.
Is this working? Can you hear? Okay.
Hi. I'm Hsien.
And I'm Sammy.
Thank you so much. We're thrilled to be here. We're from Canada. I'm very excited and honored to have the opportunity to present to you some of our work. You want us to go this way? Okay, because of the online folks. Hi, online.
Oh,
we just had
over
lunch.
here?
I hope you did too. Okay. So I'll just introduce myself a little bit. I am a palliative care researcher. I have spent 20 years trying to do research to demonstrate the benefits of palliative care, how early palliative care can improve patient outcomes. And I will tell you, even though I go to people and say early palliative care matters, they run away from me, even in my own family. And I often hear, well, that might be for different reasons, but I often hear from patients and families, even in my own family, when my mother died 30 years ago from breast cancer, or my best friend's father died of ALS in Canada, they said, I wish I had known that sooner, and why didn't anyone tell me that?
Mm-hmm. And I'm Sammy Winemaker. I'm a palliative care physician, and I work in the most incredible care setting called people's homes. And I've been working in people's homes for about 20 years now. And over time, I feel like I see the same scenario over and over and over again, where a patient and family who I unfortunately meet in the very advanced stage of their illness also feel that they're confused about where they've come in their illness, where they're at now in their illness journey, and what to expect going forward. I should mention that the two of us work in palliative care. ALS is one of the patient populations that we care for, but there's other progressive life-limiting illnesses as well.
Yeah.
Okay, so because this is international, maybe some people don't recognize Lucy and Ethel. Does anyone here recognize Lucy and Ethel? Yeah? Okay, so it is an American sitcom from the 1950s, and you might wonder why we're showing this iconic clip of Lucy and Ethel on a conveyor belt. They cannot keep up with the chocolates that are coming their way, and so they stuff them everywhere, down their shirts and their hats. And Hsien and I love this clip because to us it represents the healthcare system, patients and families. So the healthcare system would be the conveyor belt. It just keeps going, and the standard conveyor belt with the number 5 scoop. And Ethel and Lucy represent healthcare providers who simply just can't keep up, and they are stressed out as well. And the chocolates, who represent the patients and families who want to be seen as unique truffles, not just any old chocolate coming down the conveyor belt. So we often think of this metaphor.
Yeah. Yeah, go ahead.
That's my slide. We're not married to each other, by the way. Sometimes people, that's the first question they ask. But anyway, okay. So we understood that in order to change end-of-life care or the advanced stage of an illness like ALS or MND, we really had to affect change from the beginning. We had to go upstream and see what are the problems that are happening at the beginning and the middle of the illness that result in us seeing people at the end so discombobulated.
Yeah. And so how we got together as colleagues and friends. Work partners.
Yeah.
We worked on committees together in our region to try to affect change. Sammy has been doing clinician education for decades. She's won awards for it. I have been creating research interventions, trying to do education for providers. How many of you do education for providers? Some part of your role? Okay, a small part. Well,
we were frustrated.
We were frustrated because we've spent a lot of time doing that, and I think well-meaning clinicians, but it was slow moving. And one day, Sammy asked me if we teach all the clinicians, we're missing the patients and families. And so a light bulb went off for us 10 years ago, and we have started to think of what does early palliative care look like when we go upstream for patients and families. What would education look like? And so that was the beginning of this social movement called the waiting room revolution. And so in the next little bit, we'll tell you about what that is, why that matters to you, and what you can do if you want to be part of the revolution. So we actually thought it would be really easy because there's tons of evidence of the benefits of palliative care. So we thought we would take our palliative care food truck and go upstream and offer to patients and families, hey, look at all the evidence and the benefits and all the tools we have. Don't you want early palliative care? And guess what? There was no one in line for our food truck.
No one wants the P word.
Yeah, the big P word. And so, no surprise, they didn't want what we were selling because this was what was on the menu. Not surprising to many patients and families in the audience online as well. When they see these terms, they aren't looking on the right side, they're looking on the left. And many people think it feels like we're giving up and we're planning for death. So we learned many people don't want to plan for death, but they want to prepare for the journey ahead and they don't want to be overwhelmed.
Okay, so what we had to do was take all the research data that Hsien had harnessed over decades and all the patient stories, thousands of stories from the bedside, and we deconstructed what was a palliative approach, and we dove deep into the stories and the data, and then we put a facelift on all of that. We reconstructed it, put it back together, gave it a new vibe, a new mojo, something that would meet people where they were at the stage of their readiness in the beginning of their illness journey.
Can I just say one thing before we go to the next slide? Seriously. We believe that an early palliative care approach is everybody's business. It isn't just the role of specialist palliative care providers like Sammy. It's the role of all interprofessionals. And that's what we had been doing for 20 years, doing education. But the idea now is everybody includes patients and families. So how do we activate them and bring them into it too? So.
That's true. Okay, so about our gold mining. So about harnessing all the data and the stories we had, something happened. We realized that we could separate groups into two. One huge group that we labeled patients and caregivers or families who were in the dark. And the in the dark folks had an illness journey that was reflected by these words up here. Basically, they felt unsure, they didn't recognize themselves, they felt like a widget on a conveyor belt. And there was a smaller group of people who may have the same illness, but they felt in the know. So they were in the dark and in the know. And the in the know folks had a much better illness experience where they felt more empowered, more activated, more in control, more grounded, more hopeful. And so we were tickled pink about this because we could then see that 7 themes bubbled up that were the difference between being an in the dark group or in the know group. And these 7 themes that would make the difference between the two, we called keys, because they would unlock how to have an in the know illness experience. And these 7 keys have very plain language. You're not going to find them particularly sexy or innovative or mind-blowing, but they are truly the 7 things that make it or break it for an illness journey.
Yeah, and so we'll just briefly tell you these 7 keys, and I know perhaps they'll sound quite simple, but that is in fact why they work. These were metaphors that we co-designed with patients and families from all different diseases and clinicians of what the secret was. So the first one.
Okay, I just want to say one thing.
Okay.
Okay. We're so sneaky. Basically, what this represents is a palliative approach. This is a palliative approach, but we don't label it a palliative approach. We label it as these 7 keys. But if patients and families from the beginning of their illness learn how to extract this kind of information from the uncomfortable healthcare system, they essentially will be getting a palliative approach without even knowing it. Yes.
Yeah. So the first thing that we are teaching patients, families how to do is to walk 2 roads, which is learning how to hope for the best and plan for the rest. Not plan for the worst, which is what many clinicians said and they shut down. When we said hope for the best, plan for the rest, they suddenly were more open to think about what is the next steps for them. And that gray area, that vagueness, allowed them to enter into new conversations.
Mm-hmm. Instead of staying on the road of toxic positivity. Zoom out is the next key. And this is a key that teaches patients and families how to get out of the busy day-to-day of the illness and zoom out and find the big picture or the storyline of their illness that can act as a roadmap and important scaffolding to help them feel grounded.
The third key is many people think that whatever illness they have, such as ALS, that is going to define their experience. And of course it does. But the biggest thing that defined their experience was their style, how they had faced challenges in the past, and what kind of person they were, their personal characteristics. So knowing their style allowed them to lean into the patterns of their life and how that would play out in their illness, and also give intel to their inner crew, that's how the people around them, of how they might also react so that they could work together and just have, and not get so frustrated at why certain patterns weren't changing.
And have realistic expectations of themselves and the people around them.
Yeah.
Yeah?
Yeah.
Yeah. Okay. The fourth key is customize your order. And this is about helping people to identify what's most important to them, what they value, what they hold close to their heart, what they wouldn't want to give up, and to bring that to every single encounter with the healthcare system so that they are basically saying, I'm unique. This is me. I'm not a widget on a conveyor belt.
Yeah. Expecting ripple effects is what would be clear to many people in the room. It's recognizing that no person goes on an illness journey alone. There's a ripple effect on their families, their inner crew around them, and beyond. And so the families really go on a parallel illness journey, and they ought to be in the know and as prepared as they can. And so we talk about what it means to be a caregiver, how they can be prepared, and how to invite themselves and and make it as a choice. It's not assigned or delegated to them.
Mm-hmm. We know you know all of this, but again, remember, this is what we're helping patients and families understand at the beginning. Okay, so connect the dots. Does any country that's represented here have a perfect healthcare system? No, not a hand. Okay. Well, so this is about acknowledging that the healthcare systems are not perfect, and there are gaps, and that patients and families, whether we like it or not, become the important glue between transition points. And people have a right to understand their role as, illness managers and what they can do themselves to help feel like the right hand and the left hand is speaking.
You want to do this one?
Oh, sure. Invite yourself as the last one. That's the seventh one. So many patients and caregivers that we've met feel that if they are quiet and laid back and the proverbial good patient, that they will get better care. And you know what those people get? The conveyor belt. They get standard care, which is probably good for many people, but it's not bespoke or unique care. And so Invite Yourself is about helping people find their voice and encouraging them to be respectfully activated, not aggressive, respectfully activated or gently fierce in their illness journey. And if that's not their personal style, then find someone like Hsien who is more than gently fierce.
So these keys are sort of what someone told us at lunch was, if I can call you out, Jessica, but you had said you wish you had some of these keys earlier, right? If you had read them for your mom, you wish you had known this. And so this is meant as a guidebook or information for patients at the beginning of an illness, not just late stage. So I wrote just what's revolutionary. I mean, I won't pretend that it didn't take us a long time to narrow this down and get the language right so that it was clear and hopeful. That was the hardest part because palliative care is not typically thought of as that.
Yet realistic.
Yeah, realistic. Had to be patient-led. These are actions that we're not teaching clinicians how to do, although they could. It's patient-led. They're actions, they're very clear, and they can be introduced upstream in an illness right from diagnosis. So that was why we thought this was a different take on what's been out there. Mm-hmm. So we put that all into this social movement. I think ALS, this international alliance, knows what a social movement is. I mean, I think the Ice Bucket Challenge has been a great example of something that people can take and spread and do on their own. So we really sort of followed in many of the same principles to create a waiting room revolution, one where the goal was to put the human back at the center of care for patients, families, and providers. Mm-hmm. So we've done all this work. But what are the signals? This is the why you should care. What are the signals that this isn't just another research paper that's going to sit on the shelf, or that patients and families actually want this?
I was looking at everyone and I got distracted. Okay. So we, during COVID, decided that we were going to start a podcast. Because after we decided to start a social movement, which we had no idea how to do, we decided to develop a website and then also start being podcasters, co-hosts and producers. He's the producer. And we had no idea how to do that, but we learned how to do it during COVID. From your clothing closet, my clothing closet, that's the best sound system. We dropped a podcast or two, or 9 seasons, actually.
Yeah.
And so season 1 is the heart of our social movement. So I encourage you to listen to that podcast season if you're interested.
Yeah, I mean, we were trying to just test out the idea, put it out there and try it. So season 1 has each of the episodes, and we have a guest, a patient, family who talks about and represents that key. We are 9 seasons in. To our surprise, we're 3 years in. We are in the top 1.5% of global podcasts. We're listened to in 100 countries and over 125,000 downloads. I say all this because each of our guests are people that we learn from. They're not just people from the palliative care community. They represent patients, families from different walks of life, all talking about this idea of improving the patient-family experience. It has.
What about next week?
Next week, yeah. Well, that's the next slide.
Oh.
The next week. So our most popular episode is season 1, Walk 2 Roads. So people are referring back, and many clinicians refer to their patients to that. But next week, this is our month. We're at the end of season 9. Well, you'll recognize Catherine Cummings. There's somewhere who has been a great friend and ally here. So check it out. We have a little teaser out, but it's a great episode. I loved talking with Catherine. We could have talked for a long time. Mm-hmm. She was in her car. Mm-hmm. We have a YouTube video. We are now on YouTube.
She's the reason why we're here today, too.
Yeah, exactly. So, but lots of great people. Tilly Stevens is a doula from New Zealand. So international guests, lots of exciting conversations. So check it out if that's of interest. Is this me? Yeah.
And yeah,
you can.
Okay. And some people don't listen to podcasts and they don't go to websites. And so we wrote a book. We decided to do a good old-fashioned paper book, because some people like that. And so we called it Hope for the Best, Plan for the Rest, because we wanted it to be hopeful and approachable, with also a lot of realistic, actionable, practical things that are inside.
Yeah. We have some on sale at the booth outside, but it's an ebook, an audiobook, online, any bookstore across the world, which has been pretty amazing for us. And we're 1 year in, and it's doing great. But it was really meant as a guidebook for patients and families, and they have told us that when they read it, they feel empowered, activated. They didn't know there was information that they could have, because that's what it's about. Information is power, and the earlier you have information, the more they can think about what they can do or start to think about what choices they want to make. So this is an example of a book. The most common question we get is, that's all great, Hsien and Sammy, but the person I know doesn't want to know. They don't want to talk about it. They're overwhelmed. They can just day to day. This book belongs to someone, a wife of somebody with dementia, who is like, I'm day to day. I'm overwhelmed, and this is the copy of her book. It is highlighted, dog-eared. She read it in her own time somehow, and she said, there were questions in here that I'm going to ask my doctor tomorrow. So it was very practical, and in fact, when we wrote this, or the book wrote us in a way, it's a how-to guide. It's a how to be a patient, how to be a family, how to navigate an imperfect healthcare system.
Mm-hmm. With a life-changing illness.
Yeah.
Okay, and we are on social media. We had to learn that too. We tried TikTok and LinkedIn and Instagram and YouTube and Twitter, X. We did a lot of learning in COVID, because neither of us have an affinity for technology. You too, Hsien.
Yeah, oh, I'm terrible.
But anyway, so the best news was where we thought we would be run out of town by clinicians who thought maybe we were sharing our dirty laundry with the public and the citizens of the world. Healthcare providers actually have responded overwhelmingly positive about our content. And this is just one comment from someone. It totally changed my perspective and approach to patients with life-limiting illness. And I think it's also an amazing resource for patients as well, which is why we did it. But that was good news.
Yeah, and it's the language. Like, for example, we talk about, hope for the best, plan for the rest. That's different language than they were using when they were saying plan for the worst, or best case, worst case, things like that. So they're changing their language, just like patients read it, and they change their language too. All right, so what's next? How can we change the world? Which is, we are so impressed by the community you built here. I mean, instantly we walked into the room, the representation, the inclusion of patients and families into every piece of and conversation you have, it is incredible. If we had to dream up an organization of how you would want to bring the right people together to make change, you guys have been doing it. I've been doing it for 30 years. So thank you for allowing us to learn from you. But we know a podcast, or an academic paper, a book even, doesn't change the world. We need many people working together. So everyone is part of the revolution. Maybe you guys have a name for your revolution, but ours is the waiting room revolution. And we need everyone to work a little differently, or be open to working a little differently, particularly patients and families. I think that is our biggest opportunity. So we have designed, as Sammy said, a website. On our website, waitingroomrevolution.com, we have links to lots of free resources. Our podcast is free. We have our book. We have a book club discussion guide because people who read it said, we're bringing groups together, ask us questions. And one of the most exciting things we've done in the past year is partner with other organizations. So Health Canada has been a big supporter. They've had a public health campaign about palliative care. So they created this poster campaign, 3 questions to ask your healthcare team. You can see it doesn't say palliative care, it doesn't smell of palliative care, but it is a palliative care approach. It's good care. It's good person, family-centered care. So they printed 30,000 copies of this poster, put it all over, partnering with us, and it's available free on our website. And we created the clinician version of that, of when they ask you this, how do you respond? We have partnered, the revolution, as you know, people have to take it and make it their own, which I've seen examples of today in the morning. So we are putting out our 7 keys, people are taking it and making it their own. So an indigenous organization in Australia took our 7 keys and adapted it. They used many of the same metaphors, but a couple changed. The Health Canada poster campaign, Tasmania, or Palliative Care Australia, took it. You can see, obviously, the people on the left are from Canada, the people on the right are from Australia, but, very similar, but they made it their own. And that's what made the difference. And, for example, they've taken the keys and incorporated it in some of their caregiver-facing education. So we're giving it away. Please take it, make it your own, spin it to your communities, your countries. But that's how we make change. But our most exciting thing is Kathy Cummings heard us speak at a talk. She came up to us, and we decided to partner with Kim Berry, of course, from ALS Canada. And we've been working together with their patients and families, the pals and cows, and other people from around the world, actually several people, to partner on some tools that are specific to ALS.
Okay, so let's talk about the key that I mentioned, Zoom Out. It was the second of 7 keys. So what we've done on our website is we have put some illness roadmaps, or the big picture or storyline of certain illnesses. We have one for COPD, we have one for Alzheimer's, we have one for ALS, but there's another one.
Cancer, ovarian cancer.
Yes, sorry. And if I can convince Hsien, we're going to work through 20 more illnesses so that people aren't met with, we don't have that crystal ball. We don't know what this is going to look like. But we do have the footprint for many illnesses. I see you're trying to speed me up. Okay, so Zoom Out is about understanding the pattern of a particular illness. And so I have taught these illness trajectories so often in my career as a palliative care physician that I joke with Hsien that I should have had them tattooed on my body, but I don't. So let's go to the next slide. Okay, so when we went to patients and caregivers about our Alzheimer's roadmap to co-design it with them, they took one look at this illness trajectory line, and they were nauseated. They did not want to see that line and where it headed. So we thought, okay, no problem. We'll just soften it a bit and make it lighter blue. And then, because we don't want to sugarcoat this whole thing. It has to be about reality. But still, they were allergic to looking at the diagram. And they didn't necessarily always want to know which stage, what it looked like exactly. But they loved the questions on the bottom there, which we will talk about right now. Okay, so on our website, you can access the questions that patients and caregivers found very palatable to them. They felt that this wasn't particularly scary to ask, where are we now in the big picture of this illness? What can we do to be as well as possible? What are common signs that this illness may be worsening? What are important things to prepare for next? And what organizations and resources can support us? That this flimsy piece of paper gives people the right to go to their healthcare provider as a bridge for some of these conversations and not be met with things like, oh, don't go there yet. Oh, you gotta be just positive and you gotta fight, and we don't have a crystal ball and blah, blah, blah.
Yeah, and so when we did this with the ALS patients, families, and clinicians, they said the staging is very complicated, it doesn't really fit for our illness, but we love these questions. So these questions are really disease agnostic. This works, or we found it has worked across all the illnesses. So we've kept this. And so we modified that roadmap, that illness trajectory to look like this. I should just say they're launched on our website today, well, yesterday, but today. If you go to waitingroomrevolution.com, they are available now in English and French, free to download. They are, funded in part with support from Health Canada and co-designed with the International Alliance and ALS Canada with their logos on the bottom, which we're very grateful for. And so this is an example, I'll pass it to you, Sammy, of how we modified that staging. From the other ones, it's beginning, middle, late, and end stage. But for ALS, I know you can't see, it looks more like this.
Mm-hmm. So it identifies from 1 to 4 the different physical challenges that people will experience in speech and swallowing, lower extremity, upper extremity, and again, this is a conversation tool. We also have printouts actually at our table out by all the food. So you don't have to write this down or take pictures because we brought 300 copies. Thank you, Maggie. And then the next part of the roadmap is what to prepare for, how to prepare for key life changes. And this has a section about, around the time of diagnosis, then while you're living with ALS. And next slide, please.
Oh, no, that's all, we only zoom.
Oh, okay, put that back, please. All right, and also potential big decisions.
Is in the green.
And then navigating the late stages of ALS.
Come by our booth and check out and take it home. But I will say all our other ones are 1 page. With ALS, it became 2 pages because there was
revisions and
because there was a lot of nuances that we have discovered.
Yeah.
And that was important to patients and families, but also that the relevant providers who could help. So this is really customized to ALS MND, and it's 1 page front and back, I like to say, but check it out. And of course, if there are ways that it's a starting point. It is not comprehensive. It is meant to people to not feel scared to be able to talk about this early in their illness.
Mm-hmm.
Okay.
Not forced to. This is not forced on people, but those who want more information, who might be interfacing with an uncomfortable healthcare provider, now it's available for them.
Yeah.
We cut out the middle person a little bit.
So in our last couple of minutes, I just want to share with you again. So all of this is available on our website, okay? There was tools, but you come by our booth or table and we can grab some. But you can see all that's available there, the hub. We are very excited because our book, people have read it and said, before I didn't know where to start, but now I'm unfrozen, unstuck, and I know what to do next. I know how to move forward with me and my family. So the other thing they said is, I really wish there was a workbook and a course that went along with this. So we have been working very hard in the past few months. We have a workbook coming out April 2nd. Right, in the break we were, cooking at the copy edit. When the workbook comes out, we are going to have free materials for a workshop in a box, we're calling it. So for facilitators of how you could take slides, agendas, advertising, so that people can take the materials and figure out what pieces that are going to work for their communities. And we will hopefully next year start train the trainer workshops, because again, no two people or one person can change the world. We need as many as we can. And we have also been working on education, short provider webinars. That's also on our work plan. We have a lot of things on our work plan for next year, but this year we're excited to announce our workbook. And if you sign up to our newsletter, in January, everybody on our newsletter will get an advanced reading copy of our workbook. So you'll be able to see the exercises. So it complements. If our book is like a guide with stories and explanations, this workbook is very practical, like with a pen and lots of space and lines to write the answers to bring it as exercises to say, this is what I'm looking for. All right.
I taught him how to drink coffee, which I regret from the first day.
We're right at 30 minutes. So the conclusion is everyone is part of revolution. This is not about us or the book. This is about this information belongs to patients, families, and providers. We've had tremendous uptake. We really hope the book and the workbook can be the catalyst, the change, the tipping point. So, and we've had providers be like, I can use this workbook to introduce this language to my patients. So it works both ways, and we're working on that, so stick around. But we would love to do a train the trainer with ALS about how to use these materials for our workbook. And that's it, yeah. And we're looking forward to your questions. And just one last, well, there's one thing that we have to say.
Oh, yeah. Turn this way, and then we'll go 1, 2, 3.
1, 2, 3.
Welcome to the revolution.
You would think you've been better than that. Yeah. Okay, Melinda, yeah. While Melinda's coming up, because like I said, we do get some funding from Health Canada, they really want their metrics. So if anybody would like to scan that QR code, this is really important. If you scan the QR code, we have like a 3-question, 10-second evaluation, if you're so inclined. But we would be grateful. Thank you, Melinda.
Well done. Congratulations. Excellent presentation. You finished quick. You made me get my exercise in. What a really lovely presentation. Thank you so much. The inclusion of patients and families, focus on really the beginning all the way through, processing through an illness. I think those are some really important aspects in your work. So thank you so much for presenting. Yeah. We have about 10 minutes for Q&A and questions. Happy to take some questions. Anyone?
It is bright up here.
Yeah, it's true, right? Oh, we have an online question, yeah?
More than a question, 3 people online have already bought the book, so thank you.
Yay.
Oh,
nice. The proceeds from the sales went to our workbook, so we're just recycling to get more products out there. Oh, there's one over there. There's some hands waving back in the back.
You really can't see. Oh, far in the back. Hi.
Thank you. I'm Kathy Collett, a caregiver, former caregiver and an ALS advocate from Indianapolis, Indiana, that has to suffer through the U.S. healthcare delivery system. I think your book is awesome in terms of the concepts it's putting forth. The problem that we had as we tried to put some steps together, these what next things, was healthcare delivery could never deliver at the pace of ALS. Yeah. It's like I told the doctor, we're constantly throwing the ball 5 yards behind the receiver. Do you have any suggestions for how healthcare delivery can learn that ALS is a fast disease and you can't treat it just like any other project? Thank you.
Thank you.
Yeah, I guess I would say all the more reason why all of this amazing work has to start right from the beginning. And we really need to shift that desperately from, being retroactive, crisis-driven. We need to try solutions like hopefully this one to be more proactive and plan ahead and empower and activate the patients and the families to not have to go at the pace of the healthcare system and bring themselves forward when they identify that things are changing.
Yeah, and I would just add to that to say that the answer is actually only 5% of the care is provided by the formal healthcare system, and 95% of the care is provided by the family and the community. So we should not wait for the lead from healthcare systems.
You got a clap.
Oh,
Did someone clap?
Yeah. We should not wait on the lead or be wholly dependent. We are activating patients and families to seek out information so they can form their own networks and find the ALS associations earlier, because who has the answers? This room has the answers. You guys are sharing innovations, ideas. We went to the suite with all kinds of ideas and sharing. That is where they're going to find better answers than hoping the healthcare system is going to solve the problem. And I'm not saying we don't want to change the healthcare system. I'm just saying we can't wait for the healthcare system to change. We have got to empower our people to find the solutions and tap in to the associations here.
You got
right?
well
You guys are
said.
the answers.
Bravo.
Yeah.
Bravo. Very
Sorry.
well said.
Got excited.
Oh, I see a hand waving.
Cappuccino moment.
Yes. I can't see who it is, but
I'm Dr. Hsien from India. I would like to ask, do you have this book in any other language? And can we get it translated to our local language?
I understood it as, is this available in any other language?
Yeah.
So right now, so the truth is we cannot, we would love it to be translated. It's not up to us. The people have to buy the rights. Our tools that we created with Health Canada are English and French, but our podcast, our materials, all our print materials, someone could put it through Google or something and translate it and please adapt it. We haven't had anybody adapt it, but if somebody wants to or can, we would love that. We have lots of free things online that people can adapt. Or let us know, we would love that. The book and the workbook, unfortunately, because of copyright and stuff, we would love that though.
I wasn't sure if maybe there was a second part to your question that we didn't. Oh, is that enough? Okay.
that was it, yeah. So is there an opportunity, I'm going to add to that really quickly, is there an opportunity to take perhaps extracts, particularly the ALS kind of planning checklist, and translate those materials, or are they, yeah.
Yeah.
Because the organizations present in this room are quite extraordinary at making sure that things are translated both in language and culture. So that would be wonderful if that's an option.
Yes, I think the answer is yes. I mean,
Yes.
the ones that we put on our website were co-designed with Health Canada, et cetera. And so,
French.
in English and French, but let's spread it out there. They would be thrilled, like that example of Tasmania. They were thrilled that other people wanted to use the materials that, they helped to support and fund.
Excellent. Is this a question here? No. I make that up? Anyone?
That's it. Okay.
All right. Well, we will thank
Thank you.
very, very much.